Bismillahirrahmanirrahim. Quote of the day: Allah understands our prayers even when we can't find the words to say them. Today, the topic of my presentation is tuberculosis, and I am presenting it under supervision of my professor, Dr. Saira Afzal. Learning outlines, introduction, epidemiology triad, chain of transmission, clinical features, prevention, WHO response, TB control program in Pakistan, recent updates, and MCQs in the end. Learning outcomes. By the end of this presentation, participants would be able to describe epidemiological triad, chain of transmission, clinical features, prevention, WHO response, and TB control program in Pakistan. Introduction. Tuberculosis is a bacterial infection spread through inhaling tiny droplets from the coughs or sneezes of an infected person. It mainly affects the lungs, but it can affect any part of the body, including the abdomen, glands, bones, and nervous system. This March 24 is celebrated as World TB Tuberculosis Day every year. Now, epidemiological triad. In this model, the agent is the TB bacterium. Host factors include non-immune, weakened resistance, poor nutrition, and environmental factors include crowding, poor ventilation, and bad sanitation. Incubation period, the time from receipt of infection to the development of a positive tuberculin test ranges from 3 to 6 weeks. The development of disease depends upon the closeness of contact, extent of the disease, sputum positivity of the source case, and host-parasite relationship. Thus, the incubation period may be weeks, months, or years. Period of communicability. Bacilli survive in droplets for 8 to 10 days. Patients are infected as long as they remain untreated. Portal of entry. The commonest points of entry is nose, throat, and mouth. Classification. It is broadly classified as pulmonary or extrapulmonary TB. Pulmonary TB is further classified as primary disease or secondary disease, and extrapulmonary TB consists of lymph node TB, pleural TB, TB of upper way, skeletal TB, genitourinary TB, miliary TB, pericardial TB, and GIT TB, tuberculosis meningitis. Now, what is primary pulmonary TB? It is characterized by Ghon complex and consists of subpleural focus of inflammation, infected lymph nodes draining the primary, that is subpleural lesion. Secondary pulmonary TB is characterized by a focus of infection, granuloma formation, usually in the apex of the lung. The small granulomas eventually coalesce to form large areas of consolidation with central caseating necrosis. Progressive pulmonary TB, in this primary or secondary TB may go on to heal as caseating granulomas replaced by fibrosis and calcification. However, cases do not heal spontaneously or with therapy and progress to form cavities or spread to other parts of the lungs and other organs of the body through lymphatic channels and bloodstream. This type of spread is known as miliary tuberculosis. Now, how it spreads. TB spreads through the air, that is, it spreads from person to person when someone with contagious TB coughs, speaks, or sings. Latent TB infection and its TB disease. Latent TB infection is when people with latent TB infection do not feel sick, do not have symptoms, cannot spread TB germs to others, can have latent TB infection for years, have a small amount of TB germs in their bodies that are alive but inactive. Latent TB infection can develop into TB disease. And TB disease, if TB germs become active and multiply, latent TB infection can turn into TB disease. Now, these are the differences. Person with latent TB infection has a small amount of TB germs in his body that are alive but inactive. However, in persons with TB disease has a large amount of active TB germs in his or her body. Latent TB infection cannot spread TB germs to others. However, person with TB disease may spread TB germs to others. Person with latent TB infection does not feel sick but may become sick if the germs become active in his or her body. On the other hand, the person with TB disease may feel sick and may have symptoms such as cough, fever, weight loss. Person with latent TB infection usually has a positive TB skin test or TB blood test result indicating TB infection. However, a person with TB disease usually has a positive TB skin test or TB blood test result indicating TB infection. Person with latent TB infection should consider treatment for latent TB infection to prevent TB disease. Person with TB disease needs treatment for TB disease. Now, untreated latent TB infection can lead to TB disease. If the immune system can't stop TB germ from growing, they become active, multiply in body. This is called TB disease. And most people diagnosed with TB disease they become sick and after living with latent TB infection for years. Latent TB infection treatment is 90% effective in preventing the development of TB disease. Possible disease symptoms are night sweats, fever, chills, weakness of fatigue, weight loss, no appetite, cough lasting more than 3 weeks, pain in chest, coughing up blood or or sputum. Now, symptoms. In latent TB, a person with latent TB have no symptoms, no damage will show on a chest X-ray. However, a blood test or skin prick test will indicate that they have TB infection. Active TB, an individual with TB disease may experience cough that produces phlegm, fatigue, fever, chills, loss of appetite, and weight. Early warning signs. A person should see a doctor if he experiences a persistent cough for more than 3 weeks, phlegm which may have blood in it when they cough, a loss of appetite and weight, a general feeling of fatigue, swelling in the neck, fever, night sweats, chest pain. Beyond the lungs, TB usually affects the lung, though symptoms can develop in other parts of the body. It is more common in people with weakened immune systems. Like TB can cause persistently swollen lymph nodes, abdominal pain, joint bone pain, confusion, persistent headaches, seizures. Now, public health workers are responsible for finding TB contacts. A TB contact is person exposed to someone contagious TB disease. Contacts can include family members, roommates, housemates, close friends, co-workers, classmates, and others. People with TB disease can spread TB germs to those around them. The local health department will conduct a contact investigation by following up and testing those who have been close to someone with TB. Now, risk factors. Who is at higher risk for becoming infected with TB germs? Anyone can get TB. Some people have a high risk of getting infected with TB, like people who have contact with someone who has infectious TB disease, people who are born in or who frequently travel to countries where TB disease is common, like Mexico, Philippines, Vietnam, India, China, Guatemala, and other countries with high rates of TB. Healthcare workers and the workers who work or live in places at high risk for TB transmission, such as homeless shelters, jails, and nursing homes. People at high risk for developing TB disease generally fall into two categories. That is, those who have been recently infected with TB germs and those with medical conditions that weaken the immune system, such as HIV infection, substance abuse, specialized treatments for rheumatoid arthritis or Crohn's disease, organ transplants, severe kidney disease, head or neck cancer, diabetes, medical treatments such as corticosteroids, silicosis, low body weight. Complications. The complications of tuberculosis include spinal pain, joint damage, swelling of the membranes that cover brain, liver or kidney problems, heart disorders like pericarditis, cardiac tamponade. Now, prevention of airborne infection, levels of TB prevention. First is primary prevention, that is preventing TB infection. The interventions include infection control measures in health settings to prevent transmission to patients and staff. Secondary prevention, isoniazid therapy to prevent progression to TB disease, intensified case finding, early diagnosis and treatment. Tertiary prevention is preventing TB morbidity and mortality. The interventions include BCG vaccination does not prevent infection with TB but does prevent severe forms of childhood TB, diagnosis and treatment before complications develop. Symptoms and diagnosis. Common symptoms of active lung TB are cough, sputum, and blood at times, chest pain, weakness, weight loss, fever, and night sweats. WHO recommends the use of rapid molecular diagnostic test as the initial diagnostic test in all persons with signs and symptoms of TB, as they have highly diagnostic accuracy and will lead to major improvements in the early detection of TB and drug-resistant TB. Rapid test recommended by WHO as expert MTB Ultra and TUNET assays. Diagnosing multi-drug resistant and other resistant form of TB as well as HIV-associated TB can be complex and expensive. Tuberculosis is particularly difficult to diagnose in children. TB testing. There are two types of tests that can be used to diagnose TB infection: TB blood test or TB skin test. If either test is positive, further tests are done to confirm a diagnosis of TB disease. These are medical examination and chest X-ray. TB blood test. Blood is drawn and sent to a lab for analysis. Positive blood test. A person likely has been infected with TB germs. Additional tests are needed to determine if the person has latent TB infection or TB disease. Negative blood test. A person's blood did not react to the test and latent TB infection or TB disease is not likely. The TB person blood test is also known as interferon gamma release assay. TB skin test. The TB skin test, also called the Mantox tuberculin skin test, requires 2 visits with the healthcare provider. On the first test, a test is placed, and on the second visit, the test is read. That is, this in duration is measured. People vaccinated with BCG can still get TB disease. BCG is a vaccine for TB disease. It's often given to infants and small children in countries where TB is more common. It protects against severe forms of TB in children. TB blood tests are preferred for people who have received the TB vaccine, that is BCG. The BCG may make a TB skin test hard to interpret. The TB vaccine does not affect TB blood test results. TB blood tests give more accurate results in people who have received the TB vaccine. Now, treatment. It consists of first-line drugs. These are isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. Polyresistance. Resistance to more than one of these drugs, but not the combination of isoniazid and rifampicin. And multi-drug resistance TB is when there is at least isoniazid and rifampicin resistance, to which are the two most potent TB drugs. Then comes the second line drugs. These are ethinomide, prothionamide, cycloserine, terizodone, clofazimine, amikacin, kanamycin, and campryomycin. And extended drug-resistant TB is when the patient is resistant, then that responds to even fewer available medicine, including the most effective second-line anti-TB fluoroquinolone and second-line injectable amikacin, kanamycin. Then comes the novel generation of anti-TB. These are delamanid, petomanid, and bedaquiline. Now, how is latent TB treated? If we have become infected with TB but do not have the active TB disease, you should get preventive therapy. The most common preventive therapy is a daily dose of antibiotic isoniazid taken as a single daily pill for 6 to 9 months. You are not contagious if you have latent TB, as we have already discussed. How is active TB treated? If you have an active TB disease, you will probably treat it with a combination of antibacterial medications for a period of 6 to 12 months. The most common treatment for active TB is isoniazid in combination with three other drugs, that is rifampicin, pyrazinamide, and ethambutol. Now, drug-resistant TB. It means that some drugs initially used to treat TB will no longer be able to fight the TB. TB that is resistant to more than one drug, called multi-resistant TB, is very dangerous. The treatment for this type of TB takes much longer, that is 20 to 30 months to complete. Then managing tuberculosis while you're in treatment for active TB disease will need regular checkups to make sure treatment is working. However, there are some side effects associated with these medications, like upset stomach, nausea, vomiting, tingling or numbness in the hand, itchy skin, rash, yellow skin, dark colored urine. Now, let's talk about vaccine, BCG vaccine. Its efficacy is 0 to 80%. Diluent used for BCG vaccine, normal saline, should be given to all healthy infants as soon as possible after birth, unless the child presented with symptomatic HIV infection. These are of two types. Vaccine, the liquid vaccine, and the freeze-dried vaccine. Freeze-dried vaccine is a more stable preparation, stable for several weeks at ambient temperature in a tropical climate and for up to 1 year if kept away from direct light and stored in a cool environment. Preferably, it is refrigerated at a temperature below 10 degrees centigrade. Dosage is the usual strength is 0.1 mg in 0.1 ml volume. The dose to newborn aged below 4 weeks is 0.05 ml. And administration, the standard procedure recommended by WHO is to inject the vaccine intradermal using a tuberculin syringe. Phenomena after vaccination, 2 to 3 weeks after injection of potent vaccine, a papule develops, reaches a diameter of about 4 to 8 mm in about 5 weeks. It then subsides, seen covered with a crust, then healing occurs within 6 to 12 weeks, leaving a permanent tiny round scar. Complications are severe ulceration, suppurative lymphadenitis or stimulatus, disseminated BCG infection, death. Protective value, the duration of protection is from 15 to 20 years. Vaccine contraindications include generalized eczema, infective dermatosis, hypogammaglobulinemia, deficient immunity, suspected congenital immunodeficiency in pregnancy. As we all know that in our expanded program on immunization, it is administered soon after birth and only one dose is administered. WHO response. Let's talk about definitions and reporting framework for tuberculosis. Case definitions. A bacteriologically confirmed TB case is one from a biological specimen is positive by smear microscopy, culture. All such cases should be notified regardless of whether TB treatment has started. A clinically diagnosed TB is one who does not fulfill the criteria for bacteriological confirmation but has been diagnosed with active TB by a clinician or other medical practitioner who has decided to give the patient a full course of TB treatment. And this definition includes cases diagnosed on the basis of X-ray abnormalities or suggestive histology extrapulmonary cases. Now, classification based on drug resistance, monoresistant, which there is resistance to any one of the first-line anti-TB drug. Poly-drug resistant, resistance to more than one first-line anti-TB drug. Multi-drug resistance is resistance to at least both isoniazid and rifampicin. Extensive drug resistance, resistance to any fluoroquine or to a list of at least one of three second-line injectable drugs. Rifampicin resistance, that is resistance to rifampicin detected using phenotypic or genotypic methods. Now, classification based on history of previous TB treatment. New patients are those that have never been treated for TB or have taken anti-TB drugs for less than 1 month. Previously treated patients have received 1 month or more of anti-TB drugs in the past. Relapsed patients have previously been treated for TB where declared cured or treatment completed at the end of their most recent course of treatment and are not diagnosed with a recurrent episode of TB. Treatment after failure patients. These are those who have previously been treated for TB and whose treatment failed at the end of their most recent course of treatment. Treatment after loss to follow up patients have previously been treated for TB and were declared loss to follow up at the end of their most recent course of treatment. Now, what is multi-drug resistance TB? It is a form of TB caused by bacteria that do not respond to isoniazid and rifampicin, the two most effective first-line anti-TB drugs. It is treatable, curable by using second-line drugs. Second-line treatment options are limited and require extensive chemotherapy, up to 2 years of treatment. And it is the most severe drug resistance that can be developed. TB caused by bacteria that do not respond the most effective, effective second-line anti-TB can leave patients without any further treatment options, and it remains a public health crisis and a health security threat. Only about 1 in 3 people with drug-resistant TB access treatment 2020. Now, catastrophic cost. WHO's end TB strategy target of no TB patient and their household facing catastrophic cost as a result of TB disease, monitored by countries and WHO, and TB strategy was adopted in 2015, shows that the world did not reach the milestone of 0% by 2020. According to the results of 23 national surveys on costs faced by TB patients and their families, the percentage facing catastrophic cost ranged from 13 to 92%, and the polled average weighted for each country's number of notified cases was 47%. Global commitment and the WHO response. On 26 September 2018, the UN held its first ever high-level meeting on TB, elevating discussion about the status of the TB epidemic and how it and to the level of heads of state and government. SDG target 3.3 includes ending the TB epidemic by 2030. The End TB strategy defines milestones for 2020 and 2025 and targets for 2030 and 2035 for reduction in TB cases and deaths. The targets for 2030 are 90% reduction in the number of TB deaths and 80% reduction in the TB incidence rate. The political declaration of the UN high-level meeting included 4 new global targets. Treat 40 million people for TB disease in the 5-year period, that is from 2018 to 2022. Reach at least 30 million people with TB preventive treatment for at least TB infection in the 5-year period. Mobilize at least US $30 million annually for universal access to TB diagnosis, treatment, and care by 2022. Mobilize at least US $2 billion annually for TB research. Treatment for TB disease and pregnancy. Untreated TB disease presents a greater hazard to a pregnant woman and her fetus. Infants born to women with untreated TB may be of lower birth weight than those born to women without TB. Although the drugs used in the initial treatment regimen for TB cross the placenta, they do not appear to have harmful effects on the fetus. Treatment for latent TB infection pregnancy. For most pregnant women, treatment for latent TB infection can be delayed until 2 to 3 months postpartum. For women who are at high risk for progression from latent TB to TB disease, especially those who are recent contact of someone with infectious TB, treatment should not be delayed on the basis of pregnancy alone, even during the first trimester. So these are the treatment regimens for pregnant women with latent TB infection, TB disease, and HIV-related TB disease. The contraindications. The following antituberculous drugs are contraindicated in pregnant women like streptomycin, kanamycin, amikacin, capreomycin. Drug-resistant TB. Pregnant women who are being treated for drug-resistant TB should receive counseling concerning the risk to the fetus because of the known and known risk of second-line anti-TB drugs. Breastfeeding should not be discouraged for women being treated with first-line anti-tuberculosis drugs because the concentrations of these drugs in breast milk are too small to produce toxicity in the nursing woman. Now, the NTB strategy. Its vision is a world free of tuberculosis, that is zero deaths, disease, suffering due to TB. Goal is to end the global TB epidemic. Now, these are the indicators: reduction in number of TB deaths compared with 2015, reduction in TB incidence rates and TB affected families facing catastrophic costs. These are the milestones and these are the targets. This is SDG 2030 and NTB 2035. According to it, there should be 90% reduction in number of TB deaths according to SDG 2030, while for NTB 2035, there should be 95% reduction in number of TB deaths. 80% reduction in TB incidence rate, and NTB 2035 target is 90% reduction in TB incidence rate. Now, pillars and components are integrated patient-centered care and prevention, bold policies and supportive systems, intensified research and innovation. The top 10 priority indicators for monitoring implementation of the NTB strategy at global and national level, these are the indicators, and these are the recommended target levels. That is greater than 90% TB treatment coverage, greater than 90% TB treatment success rate, 0% percentage of TB affected household that experience catastrophic cause due to TB, and there should be greater than 90% percentage of new and relapsed TB patient tested using a WHO recommended rapid test at the time of diagnosis. Then this is National TB Control Program. This is the homepage of their website. The vision is a TB-free Pakistan with zero deaths, disease, poverty caused by TB. Mission statement is effectively end the TB epidemic in Pakistan by 2035. And goal is to get back on track to end the TB epidemic by 2030. Pakistan ranks 5th among the high burden countries in the world. The prevalence, incidence, and mortality per 100,000 population per year from TB in Pakistan 340 to 5,920 respectively. National TB Control Program revived under Ministry of Health to a declaration of TB as national emergency in Pakistan in 2001. The objective is to increase the number of notified TB cases, to reduce by at least 5% per year by 2020, to strengthen the programmatic and operational management capacity of the TB control program. Now, this is the tuberculosis profile of Pakistan. We can discuss it further. Here we can see that there has been 45% men, 41% women, and 14% children who fell ill with TB according to 2020 report. And 46,000 TB deaths were reported in 2020. And there was 48% TB treatment coverage, and there was 93% treatment success rate according to 2020. And these are the graphs of incidence, new and relapsed TB cases notified, and HIV positive TB. And this is the graph of HIV negative TB mortality. Now, coming to recent updates, according to WHO vaccine figures, a total of 1.6 million people died from TB in 2021. Worldwide, TB is the 13th leading cause of death and the second leading infectious killer with after COVID-19. In 2021, estimated 10.6 million fell ill with TB worldwide, 6 million men, 3.4 million women, 1.2 million children. TB is present in all countries and age groups, but TB is curable and preventable. In 2021, 1.2 million children fell ill with TB globally. Children and adolescent TB is often overlooked by health providers, can be difficult to diagnose and treat. MDR TB remains a public health crisis and health security threat. Globally, TB incidence is falling at about 2% per year, and between 2015 and 2020, the cumulative reduction was 11%. This was over halfway to the NTB strategy milestone of 20% reduction, as an estimated 66 million lives were saved through TB diagnosis and treatment between 2000 and 2020. Globally, close to 1 in 2 TB-affected households face costs higher than 20% of their household income. The world did not reach the milestone of 0% TB patients in their household facing catastrophic cost as a result of TB disease by 2020. By 2022, $13 billion is needed annually for TB prevention, diagnosis, treatment, and care to achieve the global target. Ending the TB epidemic by 2030 is among the health targets of the UN Sustainable Development Goals. Now, this is the article on association amid the comorbidity of diabetes mellitus in patients of active TB in Pakistan, a matched case control study. This study aimed to test the association between diabetes and tuberculosis, and the association between the risk factor and tuberculosis was estimated by a univariate analysis, and positive association was found between diabetes and tuberculosis with odds ratio 3.32. A high frequency of diabetes in cases as compared to control were observed with a higher significant p-value. Now, moving on to multiple choice questions. Tuberculosis is an infectious disease that mostly affects the lungs. The causative agents that cause tuberculosis are communicated from person to person via minute droplets discharged into the air by coughs and sneezes is Clostridium difficile, E. coli, methicillin-resistant Staphylococcus aureus, Mycobacterium tuberculosis, Salmonella.
D.
Yes, D is the right answer. MCQ number 2. Tuberculosis infection control is a set of measures designed to reduce the risk of transmission within an ABC population. Mycobacterium tuberculosis can be transmitted through which route? Airborne transmission, fomite transmission, vector-borne transmission, oral transmission, zoonotic transmission.
A.
Yes, A is the right option. MCQ number 3. Patient is a 30-year-old man who was admitted to the hospital from home after suffering from a week of coughing, excessive nocturnal sweating, loss of appetite, hyposomnia. The patient has a history of IV drug abuse and has been diagnosed with hepatitis B. Chest X-ray shows consolidation. The following is the most common cause of this condition: actinomycosis, aspergillosis, constrictive pericarditis, histoplasmosis, tuberculosis.
E.
Yes, E is the right option. MCQ number 4. When bacteria become resistant to the drugs used to treat TB, drug-resistant TB can develop. Drug-resistant TB is transmitted in the same way that drug-susceptible TB is. This type of TB takes longer to treat and takes at least dash months to complete the treatment. 9 months, 6 months, 3 months, 20 to 30 months, 2 months.
D.
D is the right option. MCQ number 5. When people live and work in crowded and poorly ventilated surroundings, tuberculosis can spread swiftly. Tuberculosis is 18 times more prevalent in those who are infected with DASH. Common cold, diphtheria, gardasil, HIV or AIDS, infectious mononucleosis.
D.
Yes, D is the right option. MCQ number 6. In the XYZ community, patients with relevant clinical manifestations such as coughing lasting more than 2 weeks, lymphadenopathy, fevers, night sweats, weight loss are suspected of having pulmonary tuberculosis. People had received the tuberculosis vaccination in the past. Which tests give more accurate results in people who have received the TB vaccine? Blood test, bronchoalveolar lavage, chest x-rays, culture of sputum, lung biopsy.
E.
A is the right option. It is blood test. MCQ number 7. When antibiotics were first introduced to treat tuberculosis in the 1940s and 1950s, the number of cases in XYZ developing countries started to fall. However, the number of TB cases began to climb again after 1985, which epidemic was a major contributor to the increase in tuberculosis infection in the XYZ country after 1985. Ebola epidemic, HIV epidemic, plague epidemic, yellow fever epidemic, Zika virus epidemic.
HIV epidemic.
B is the right option. MCQ number 8. Patient XYZ, 35-year-old man who was admitted to the hospital after experiencing a week of cough, profuse nocturnal sweating, loss of appetite, hyposomnia at home. Tuberculosis was diagnosed. Tuberculosis was diagnosed after he was seen by an emergency room physician. Patient XYZ was prescribed isoniazid, rifampin, pyrazinamide, ethambutol even days a week for 8 weeks, then isoniazid and rifampicin 7 days a week for 20 to 4 weeks. In this scenario, what will be the level of TB prevention? Primary prevention, primordial prevention, quaternary prevention, secondary prevention, tertiary prevention.
D.
Yes, D, secondary prevention.
Secondary.
MCQ number 9. A 39-year-old HIV positive man from Uganda has recently immigrated to the US and is being evaluated at the clinic. He was diagnosed with HIV shortly after arriving in the US. He is asymptomatic Iger is ordered as a part of her initial evaluation to check for latent TB infection. The result comes back as negative after a few days showed. Patient blood did not react to test and TB disease not likely. She has had Mycobacterium tuberculosis for an indefinite period of time. She has likely been exposed to Mycobacterium tuberculosis but is unlikely to have active disease. She most likely received the BCG vaccine more than 10 years ago with stimulated cross-reactivity proteins used in the agar. The likelihood of tuberculosis infection in the patient cannot be determined by the test result. Any guess?
D.
A is the right option. That is, patient blood did not react to test and TB disease. Yes. MCQ number 10. Point of care TB testing includes testing people admitted to hospitals, testing people at a peripheral clinic, and testing people in a community setting or at home. Which of the following technology is suitable to a point of care testing program in which treatment decisions are made during the same visit in the XYZ tuberculosis treatment campaign? Bronchoalveolar lavage, chest X-ray, culture of sputum, lung biopsy, expert MTB ultra.
C.
Is the right option. This is the key of MCQs. This is the YouTube link of presentation. And thank you.
Thank you very much, Dr. Meha. Very nice presentation. However, I want to add few things, and I would like you to please add